Thank you very much. Thank you. Okay, good afternoon everybody and welcome to the meeting, and appreciate you being able to accommodate the earlier time to be present today. Apologies for absence today. Andy, I've got Councillor Blizzard, Linda Gatecliffe and Mavis Harrison.
Yes, Chair, that's the apologies I've received this afternoon.
Okay. Thank you very much. And then we'll move on to the agenda proper, and we'll go for item 2, Chair's remarks. And the report that we've got in front of us obviously just gives us some updates of the position from the Chair's point of view. We don't want to delay too much today on it because obviously we have very important papers in front of us. But as we go along, if there's anything, I will obviously bring you up to date. Item 3, Members' Declaration of Interest. In the usual fashion, if you have interest, could you declare them now, please? Or if not, as we go through the agenda, if you want to make known any last-minute declaration of interest, please indicate, and Andy and our members' clerk will make note of them. Before I go on to the agenda proper from the last meeting, at this point, can I just remind members of the protocol for the online meetings? Questions and comments in the box, please. And at the same time, can I also welcome the press that may be listening in. I'm sure David, who always attends our meetings, finds them very informative. And at the same time, members of the public who may want to be part of this meeting today. Just a little light-hearted note, if I may, on that. You'll all recall Jack Williamson, who was a long-time member of our committee. Well, I'm pleased to say that Jack has been enabled to become IT literate with the support and help of our tremendous officer, Mark Tolson. And Jack is hoping to plug into the meeting today, hoping he hits the right button, he tells me. So, Jack, if you're out there listening into the meeting, welcome and keep safe. With that, I'll go on to the item 4. Any items which the Chair has agreed on urgency, I have none. And then we'll go on to item 5. And I understand, Olivia, you want to speak on item 5?
Yes, thank you. And hello, Jack. I hope that you can hear us. Can I just say that I was reading the Wakefield
Olivia, can I interject, love? Olivia, yes. Can you take your sound up, please? You're very faint.
Oh, dear. Can you hear me now?
That's better, love. Good.
All right. I was reading the Wakefield Express this morning, and of course we've got this continuous issue about having to charge taxpayers in Wakefield for the care of our elderly and disabled residents because the government won't produce a relevant paper that says how it's going to be funded in the future. And then
Excuse me asking, Olivia, on item 5, on item 5, which page are you referring to and which minute?
The page 7, item 31.
Thank you.
And so the newspaper article prompted me when I was looking through the minutes to say, what are we actually paying for when in fact we've got this situation in these 2 homes and even worse situations further on the agenda, and what is being done about them?
Okay, appreciate the question because that comes up under the report later on in the agenda, Olivia, in particular discussions that we've had as a result of the last meeting. So we'll note that question and bring it into the relevant minutes later on. With that comment from Olivia and a question, if there's nothing else, can we move on and accept those minutes, please? I'll take that as a yes. Okay, that takes us on to item 6, which is the COVID update report, pages 9 to 16. And obviously the purpose of this report today is to receive the update on the local position and the response to COVID-19, and as well as that to receive assurances and actions and future planning to recover and reset services, together with actions to mitigate against the third wave. Well, I reckon we're in the third wave and it's extending a bit. At this point, obviously to speak to the paper and answer questions and comments, today we have with us, we've got Ruth Unwin and Pat Keane from the CCG. Welcome to both of you.
Thank you, Chair.
We've got Andy Smith, who's standing in for Trudy Davis, Chief Operating Officer of the Mid Yorkshire Trust. Welcome, Andy.
Thank you, Chair.
Then we've got Sean Rayner, Director of Provider Development and Chair of the Mental Health Alliance, who are going to be in attendance and speaking to this item. At this point, obviously, you know, there's this report that we're all going to be listening to and questions today. This report probably will, and I'm assuming it will, it's built on the evidence as to when this report was written, and it's covering different aspects. I'm sure our representatives here today will be able to update some of the issues that questions and comments may arise from because of the demands on the service, etc. So with that, can I ask who's going to lead on the report, please?
I'll just introduce, if that's all right, Chair.
Okay, this is Ruth.
Sorry, it is Ruth Unwin, Director of Corporate Affairs for Wakefield CCG. And I suppose before I go into the paper, I'd just like
excuse me, Ruth, as well. I think you're going to have to speak a little bit louder as well, so that our public colleagues can hear as well.
Okay, yeah, I'll do my best. Right.
Okay.
So I wanted to just preface the paper before I go into any of the detail, just by saying that the whole system, so health and social care, had our regulatory meeting with NHS England earlier this week, and we got really positive feedback about how we are working together as a whole system. And I think it's worth just saying that we couldn't have got to, notwithstanding how difficult the last few months have been, we couldn't have got to where we have as a district without the efforts of social care, the independent care sector, care homes. All have worked very, very closely together to ensure that the whole health and care system worked effectively. We come at this from the perspective of what the health contribution has been, but I recognise that you've had previous presentations from social care as well, and that are complementary to this. So I'll just sort of draw out a few headlines, and then, as you say, colleagues will bring us more up to date, because obviously this paper was produced just after the Christmas period and things are very rapidly moving. In terms of the infection rate in the district, I've just provided the link because that does change on a daily basis, so the link's provided in the paper, but there has been some improvement as a consequence of lockdown. I think it's fair to say not the level of improvement that we would want, and it is still fluctuating. So from day to day there is still a sort of every now and again just slight increases in the number of infections. What is quite a positive indicator is that the rate of infection, so the rate of people who are tested and then go on to prove to be positive, is coming down slightly, and that's something that we should be proud of. In terms of vaccination, this is probably the most rapidly moving picture, but since the report was produced, primary care sites open, so those are static sites distributed around the district, run by our primary care colleagues, with considerable support from CCG colleagues and volunteers who are supporting quite a lot of the administration and marshalling of those sites. And this week we opened our first mass vaccination static site for the public, which is at Navigation Walk. And we've also, in this week, opened a pharmacy run site at Morrison's on Dewsbury Road, and on 1st of February, which is next Monday, Pontefract Squash Club will open as a pharmacy run site. So that means that we've got really good coverage in terms of local sites. We're also running roving vaccinations into care homes and to individuals who are housebound, so that's working alongside that to make sure that those people who are unable to get to a vaccination centre still do get access to a vaccine. In terms of the uptake of vaccines, it's been very positive. There are communities that we are very proactively targeting to encourage them to come forward for vaccine, very conscious that there are some myths around in the community that are discouraging people from coming forward for vaccine. So we're working very hard, particularly the public health team, on addressing that. And we've got, in terms of the over 80s group, we are the highest in West Yorkshire in terms of coverage of over 80s. So that again is very positive, and we're now working on the 70 to 79 age group. And by the end of this week, 100% of care homes will have been offered the vaccine. So that again is one of the things that we've been measured on. In terms of testing, I don't think much has changed since we last reported to the committee. So we've got a combination of both pop-up temporary sites that are distributed around the district, and we've obviously got the static site now, again close to the bus depot at Bellevue. And Test and Trace locally is working proactively through public health to chase up people who are contacts of somebody who's tested positive, who haven't been able to be contacted through the national programme. In terms of the support for vulnerable people, we're obviously, because of lockdown, we're back to a position where we've got a number of people in our community who are shielding because they're clinically extremely vulnerable. And in the last week, the local authority, with support from the NHS, sent a letter to every household, and that includes information about the support hubs and how people can get help if they need that while they're shielding. Care homes, we have, I know that Lisa and Nicola came, I think it was the last meeting, and talked in some detail about what's working, how things are working in terms of care homes. They are a fundamental part of the system, and I think we cannot underestimate the contribution that care homes are making to the health and care system and the challenges that care homes have experienced. I know that I've talked to the committee before, and others have, about we recognised really early on in this pandemic that care homes needed a lot of support to ensure that they were sustainable and that they could manage patients with increasing complexity, and we've continued to provide that support. The only other thing I suppose that is that I wanted to just pull out in that is that we have got a number of care homes that provide capacity for people who have tested positive for COVID in hospital, so that they can be discharged promptly from hospital into a safe and isolated environment. And we've also now got dedicated capacity at Earls Lodge nursing home for people who are COVID positive. So that helps in terms of managing flow of patients who are still COVID positive out of hospital into a safe environment. In terms of primary care, again, we had a really comprehensive report last time. There's not an awful lot that's changed in terms of the primary care offer, that's still the same comprehensive offer that we described last. Has changed is that there's now an additional pressure on primary care to support and service the vaccination programme, and our primary care clinicians are working incredibly hard to make sure that they are splitting their time between providing a service to their registered patients and supporting the delivery of the vaccination. And there is continued work on the shared care pathways where people are unable to get access to secondary or referral into secondary care and are being managed with more complex conditions in primary care in a shared way, with GPs working closely with hospital consultants. Andy Smith is here to talk about hospital. I think it's probably just worth just highlighting really, sorry, I just turned my phone off. It's probably just worth highlighting that we are experiencing, we did in wave 2 experience higher levels of activity than we did in wave 1. We haven't hit those levels again in this wave, but there is considerable demand on the hospital at the moment, and we deliberately didn't put activity data into the paper because it moves so rapidly. So I think Andy will come on to talk about that in a little bit of detail later. But we are using surge capacity as we normally would in winter, and we're managing additional demand in using tried and tested mechanisms that we've used before in terms of managing that. A&E attendances as you'll see from the paper, are lower than they were in the same period in previous years. But that doesn't mean that it's not challenging, because obviously we've got additional demands on A&E in terms of having to manage social distancing and making sure that there isn't crowding in the department. So that means that we do need to keep those numbers low, and we've put in place a number of additional measures to divert people away from A&E who don't need to be there. So what we're doing is trying to, as much as possible, encourage people to use alternative services through primary care, through 111 and through the urgent treatment centre. You'll see again from the paper that there were significant improvements in planned care over the summer when things quietened off. That's been more challenging since we've moved into managing more COVID patients, but we still, our performance is good, particularly for the cancer targets. So for cancer 2-week waits, we are exceeding the national target at 98% compared with the 93% target. For the 62-day referral for cancer, we're on 84% compared with an 85% target. For other referrals to treatment, there are challenges, even though we are using the independent sector to manage as much planned care as possible. And as you will see, there are, at the point when we reported this at the end of December, there were just over 1,000 patients who've been waiting more than a year for treatment. And obviously that's something that, as a whole system, we need to find solutions to. So as I say, Andy will be able to talk about that in a little bit more detail. Again, mental health and learning disability, we've referenced it in the paper, but again, there was a very comprehensive report on that last time. Sean is attending so that he can give some more information on that if it's wanted. And then the final thing I was just going to refer to was in terms of long COVID, which is there is increasing awareness that a number of people experience longer term after effects after COVID. And we are working proactively to develop a multidisciplinary team approach, which will include hospital, community and primary care clinicians, to provide support to people with managing both the physical and psychological impact of long COVID. So that's just a quick summary of what's in the paper. I don't know if colleagues want to come in at this point to add anything, Andy, Pat or Sean, if there's anything you want to add at this point, or whether we're happy to just go straight to questions.
Before you do that, Ruth, yeah, I mean, obviously coming to committee today, as I said, things have changed since this report was written. Do you have an update situation on the numbers of patients in hospital at the moment?
I think Andy will be able to give that information.
Thanks, Councillor. If I can interject on those numbers, from the report that's just gone out this morning, we have 232 positive COVID patients in the hospital bed base. Those numbers have increased, but kind of stabilising a little bit at the moment. But we have seen an increase since this report was submitted. That takes us just around 95% of our bed occupancy. Obviously, that places the trust under significant pressure. There are 36 patients in higher acuity this morning. There's 130 patients at Pindefears site, 54 patients positive at the Gooseberry site. We are into 43 extra capacity beds as per our winter plan. We've opened this week an additional ward up at Gooseberry, Ward 14, which is normally a surgical ward, to try and facilitate flow. As I'm sure members are aware, this is a very challenging time trying to keep our flow out of emergency departments with the separate high risk suspected COVID patients, and trying to separate those from the non-COVID patients and maintain those flows and safety. The way we achieve that, we are fortunate at Mid Yorkshire that 50% of our beds are side rooms, and therefore we're able to flow into the side rooms, await for definite results. Sometimes we get indeterminate results and have to do further testing, so that when we are cohorting, we're trying to cohort as safe as possible to maintain the flow. We did have significant challenges last week, and I would like to take this opportunity to thank our system partners who have rallied round and really supported the Trust. And I think I must reiterate what Ruth has said. Through the system, we are working very collaboratively together with quite a lot of meetings. I think Pat and I probably see each other far too often during the week, but I'd like to thank Pat and the group for all their support to the Trust, and this week we've asked for mutual aid. One of our real impacts has been around staffing numbers. As of this morning, we have 8.3% of the workforce available to work. That's 332 people. that are absent due to a COVID absence, that doesn't include the 162 staff personnel that are shielding. But we do have, this morning, 73 personnel that are COVID positive, and that's a real concern for us. We're taking many measures to make sure that staff maintain that social distancing, use PPE appropriately. One of the points that Ruth alluded to is our emergency departments. Outside of COVID, we would say that our capacity is 75 at the Pindefears site. That is reduced to 63, trying to maintain that social distancing to keep our staff and patients that are attending as safe as we can. Unfortunately, sometimes last week that the number attending went up to 100, and it did result in some what we call breaches in our ambulance service offloading. And we did last week enact parts of our major incident plan to get through those measures. This week I'm pleased to say we're in a slightly better, improved position. Again, but we are working collaboratively with our system partners to provide the best care we can for the patients in these most challenging times. I think it would be remiss of me to not identify our gratitude to the staff who are, I think, very tired, very stretched, working many extra hours above what they are contracted to. And one of the measures the trust had to take this week was offer to buy back annual leave, a measure that we would ideally avoid. But we've done that to try and make sure our staffing levels are safe for the care of our patients. And a huge gratitude to our staff that are working well above the call of duty to enable provision of care to our staff. Happy to take any questions, Chair.
Okay, thank you very much, Andy. Could I just remind presenters who are reading their reports today of updates, just to take a breath in between, that's not to be too rushed, because obviously we're all listening in from our various computers, and it's very important information that we want to digest as we go along. Thank you for that. Right, we've got some questions. Martin Johnson, yeah, question?
Yes, thanks, Chair. Thanks for that, Ruth. Good news that you're opening more centres for people to get a vaccination. However, I'm concerned that beds are still at a premium. And we hear that people are being transported from down south and elsewhere up to Yorkshire, and I understand that, but I have to ask the question, what's happening with when we spent £500 million plus on Nightingale hospitals that we're told are not in use or not being used? So my concern is, why aren't they being used, and if so, why not? And the other question is, regarding the vaccine.
We can't hear you very well, Martin.
Regarding the vaccine, we read, and a couple of people have been in contact with me, we read that GP surgeries won't sign up, they'll only sign up to the Oxford vaccine and not the other one because it's too expensive, apparently, to hold on to before they with the refrigeration. So I'm just concerned that we may not be doing as many vaccines as possible because we're only using one type of vaccine.
Andy, are you going to answer that?
I'm happy to answer. I think
okay.
Both those. I think in the Nightingale hospitals, I suppose the position always with the development of the Nightingale hospitals was that they were a facility that we hoped we would not need to use, that we would be able to maintain optimum capacity within local hospitals. So they were there, provided to be in reserve as a last resort. And we've been very fortunate in this area that we've been able to maintain that position, and that the Nightingale hospitals, whilst they haven't been used to support COVID patients, have been used to support things like diagnostics, which have taken pressure off local hospitals to allow them to manage COVID patients. In terms of the vaccinations, you're absolutely right in that the Pfizer vaccine is less stable and more complex to transport and use, and therefore is more suitable for using at the mass vaccination centres and at places like Mid Yorkshire, where they're vaccinating at scale for patients for staff in the hospital. So the primary care sites, mass vaccination site, and the hospital site all have the capability to use the Pfizer vaccine. The AstraZeneca vaccine is more suited to areas where they're doing low volume, and so that is more likely to be used ultimately in community settings.
Can I come in there, Ruth, if I may?
just come back on that,
The
Chair.
answer to the question about the Nightingale hospitals.
Yeah. Can I just come back on that Chair?
Just a moment, Martin. Ruth, is it not a fact that the Nightingale hospitals couldn't have opened without the appropriate staff, which would have meant drawing staff from the trust? And this is all over the country. So the issue of the staffing of the Nightingale's hospital was the first priority to deal with COVID patients. And that's the reason that they didn't open in the first place, because the staff weren't there to cover them. And the diagnostics part of it, obviously, that's of benefit to the hospital. But the reason all the money was spent on the Nightingales, as Martin has said, was for COVID. And bearing in mind the comment that Andy's just made about the issue of staffing at Pindefears, obviously we appreciate the difficulties and how they've had to work in these circumstances, and that's a worry as well. But I think we need to get the message right about the Nightingale hospitals.
Chair, can I come in?
Come in to deal with them weren't there in the first place. Martin,
Chair,
you wanted to come back?
Yeah, I did, Chair, because obviously, you know, we see on the news as well a few months ago they were decommissioning the Nightingale hospitals, you know, and then obviously we find ourselves in a third wave, which is difficult to understand. That you spend all this money, obviously, which is good for people that unfortunately get this awful disease, and then we dismantling them because we've not used them. And I just find that scenario a little bit crazy. And just one final question, Chair, going on the 90% occupancy of people in the hospitals, do they have a number on people that have gone in for non-COVID care that actually have come out or caught COVID in the hospital?
Who's answering the question, please? Is it Ruth or Andy?
I think Pat wanted to come in on Nightingale, and then Andy will probably come in on the COVID in hospital.
Thank you.
Chair, on the Nightingale, Chair, thank you. I think there are two issues. Clearly, the Nightingale, the plans for Nightingale are a national level. So the resourcing and organisation of them was initiated at a national level, and then for the local one, it's the Leeds Acute Trust. But I think there are two issues. It was to plan on to use the data nationally and internationally to look at what the likely pressures would be. What we've seen in West Yorkshire and Harrogate particularly is that we are able, because we have an acute network of hospitals and ICUs, we have a very good network arrangement to be able to support each other, but also to deal with influxes. It is quite right that the balance at the moment is to be able to support local hospitals and the challenge that we have with staff, rather than with the Nightingale. But as Ruth said, at the moment, the levels of activity would indicate that we wouldn't need to utilise the Nightingale Hospital. Clearly, that was the planning and resourcing of the Nightingale Hospital was based upon scenarios for the large influx of patients. So we've seen the impact on the south of England compared to the northeast and West Yorkshire, so we're not in that position. But I think it would have been very remiss of us as an NHS not to plan for the worst case scenarios. Clearly what we've seen since then is the significant impact of COVID upon staffing, and despite the best efforts of hospitals and others in relation to PPE, this is a very contagious disease. The trusts work very hard to ensure that they keep the spread to a minimum. And clearly that means testing. Of course, the other option is if staff are showing any symptoms or test positive, then they have to go off sick immediately. So that factor is playing into the challenges of the trust. But I think in terms of the Nightingale position in Mid Yorkshire and the wider West Yorkshire system, we are managing that capacity. It is very, very tight, but I think at the moment that Nightingale facility isn't needed and utilised. But there is a fact, I think, as you said, Councillor Rhodes, that there is a challenge with staffing. And I think the acute trusts at the moment, would prefer to work within the network that they've got of specialist facilities. Andy might want to come back on that, but I think that will be the position as I see it.
Thank you, Chair. If I can input to help people's understanding. So yes, at the moment we are trying to manage looking after our patients within our acute trusts, and within the Wyatt collaboratively in the ICS, we are making sure that the network is informed and we try and manage our patient trust, because at the moment it would be a real challenge, despite the previous planning, to release staff to man the Nightingale. So we are trying to manage in-house. We have got our surge and super surge plans in all acute trusts so that we can expand our ability to provide that higher acuity care as it's required. And that's quite a detailed plan to do, because we have to look at oxygen levels, how of each of the oxygen risers we can have so many patients on oxygen, and all that planning has been done. To the extent we've also done that planning for Dewsbury, so if we had to surge into higher acuity, not intensive care, but more into the higher acuity, what we call RQ, where patients are on non-inventive ventilation, we can provide that care. So we have surge and super surge plans to manage that, and all acute trusts have to provide those, and we are regionally submitting them, and they are extensively coordinated. On the second question from Councillor Johnson, I think, yes, there is a risk of patients coming to hospital catching COVID, but a huge amount of work is done there. Pat's already alluded to the amount of work we're doing around testing. Staff are testing twice a week with the lateral flow systems, and then if they do test positive, they're followed by a PCR, which is a more sensitive and specific test. We are monitoring our staff very closely, and any signs and symptoms they go off. I'm not sure if all the councillors are aware, but all acute trusts have an internal test, trace and isolation system who follow the tracking to try and prevent our staff. If they do become infected, but then we obviously make sure we're taking the correct measures. The nosocomial rate, which is where people acquire the infection in hospital, again, that is monitored extensively closely by our chief nurse and the infection prevention and control team. There have been some patients that have acquired the infection in hospital. Initially that seemed higher than it was, and what we have done, keep following the national guidance, and again this was released mid-January, updates on that, which the trust has adhered to that guidance. We are testing patients on a regular basis. People may know that there's a 5-day infection development time often, so patients can come in initially their test is negative, so we are testing patients at days 3, 5 and 7 if they've had a negative test. If they've had a positive test, the evidence now states we don't retest for 90 days. There's very clear step down guidance at the end of their day 14. On day 15, what's called blue to review, patients are then reviewed, and if their symptoms have improved, they've not required any medication to keep their temperature down, they are then stepped down from a red cohort area into a green area, because obviously they've now gone through their period where they can be infectious to others and step down. This is a very complex piece of work, and we keep reviewing our processes around that, because obviously our aim is to keep our staff and our patients as safe as we can. But I can't give the exact number, what's known as the nosocomial rate, and we have to report on our daily SIP reps a number of patients that are community acquired, probable community acquired, probable hospital acquired, definitely hospital acquired, but that data is available if required.
Okay, thank you, Andy. Any other questions to Ruth? I've got Councillor Tennant. Clive? Councillor Tennant?
Thank you, Chair. On vaccine rollout, I have to say everybody I know who was being vaccinated speak very highly of the procedure at the vaccination centres. I think that's commendable. I know people in Pontefract are going to Civic Centre at Castleford, and people from Featherstone are going to Normanton, and it's been mentioned about the squash club in Pontefract opening up next week. My question is the vaccination programme going to be rolled out to local GP surgeries?
That over to you, Ruth or Pat?
Ruth, are you?
Sorry.
Ruth, can you hear or Pat?
I expect ultimately the vaccination programme will roll out in the same way as the flu vaccine programme, but at the moment the plan is around creating larger vaccine centres so that we can get a quick throughput of people as we do this first rollout of vaccines. So it's not an immediate plan to roll out to individual GP practices, but ultimately we would expect that it will become business as usual if people need to have repeat vaccine. So that will work in the same way as flu vaccine, where there'll be a range of different venues in the community, including GP practices, where people could access the vaccine.
Thank you, Rolf.
Okay, Pat, I'm just going to come back in, if I may. We're on about the staff in the hospitals and the questions and comments about, you know, the rate of infection and staff testing positive. You actually said, and I do think it was a mistake, that if they have symptoms or test positive, they may have to take time off work. Well, I'm sure that was an oversight in wording. It would be that they would have to take time off work.
Yes, apologies, Chair. That should have been that they have to. Yes, absolutely.
Okay, we didn't want the wrong impression going out.
Thank you, Chair. Thank you for clarifying
that. No problem, yeah. Now, in terms of the... I've had some questions, Andy. We've had some questions sent via email from Mrs. Harrison. Mavis can't get in through the internet, so we got questions in this morning, and if I could relay those messages. One was that Mrs. Harrison had her vaccine on 9th of January at Sandal Rugby Union Club, but she was never issued with a vaccination card, of which she then had to pursue via her GP. A concern particularly if vaccinated patients are admitted to hospital or require some other medical intervention and need proof of vaccine. As a matter of best practice, has this been resolved? And however, the process that she commends was well marshalled, well organised, and booked in to the 15-minute wait at the end. So was this an oversight down at Sandal Rugby Union Club? As my understanding, as I'm sure with others, is that you're either issued with a letter or a card with the date that you've had your first vaccination on.
Yeah, and that's my understanding as well, Chair, that the person, once they've received the vaccine, should get something that says that they've had it, a card. I know that Mavis attended our patient and community panel just after she'd had her vaccine and was incredibly complimentary about the process at Sandal. She didn't mention that issue at the time, and obviously if she had done, we'd have supported her in pursuing that. I think the one thing that we would want to reinforce is that the current guidance is that people should behave no differently once they've had a vaccine. So evidence of having a vaccine wouldn't change the way that somebody is treated in any way at all.
I think the point that she's making, obviously, is the reference to the date that it's happened, and for any reference in terms of hospitalisation, yes, or onwards. Yeah. Could you make note of that, Ruth or Pat, and make inquiries that...
I'll chase it up, and I'll pick it up directly.
We can respond to Mavis that that's been chased up. And the second one, I'm just... oh, yes. It was on page 13. It was about the rapidly put in place consultation arrangements. Will this be a permanent or temporary arrangement? Will patient choice via the choose and book system be restored?
Chair, the plan is obviously once we get through this next third wave, which we're still climbing in at the moment as far as the hospital is concerned, is that we will try and restore through the reset group every activity that we had in place. Now obviously we are doing very detailed reviews of what we've learned from the second wave, and I'm running that at the moment in our trust, and I know that on behalf of the CCG, Michaela James is doing that to ensure that we take the lessons learnt and the way that we can improve our services. And there's clearly some benefit where having non-face-to-face consultations works. There's also some benefit where we can try and do, use the terminology, one-stop shops, when a patient comes in and they move around all the different aspects they need for the investigations, for say, of that issue that they're having to manage. So we're taking the actions to learn, to improve and put those in place, and I think Choose and Book would definitely be one of those that we would reinstate as soon as we could once we move out of this third wave.
Thank you. And the last question from Mavis is on page 12 regarding the Wakefield Intermediate Care Unit. And her question is, does this incorporate the designated settings as item on paper on the 22nd of October 20, i.e. Snidel?
Chair, if I can pick that up?
Yes, please. So
the walk-in centre is actually it is part of the acute trust. It is an intermediate care facility. It is registered by CQC anyway as being part of Mid Yorkshire. It has got a specific function, obviously, to support people pre-discharge, to support with rehabilitation, etc. It's not part of the community CQC designated facilities within the care homes. It's a very important facility, and we work very closely with the trust in terms of the types of patients that can be facilitated and discharged through that unit. But it isn't part of the community CQC as in the care home facilities. It is part of Mid Yorkshire, and so as a result, it's got CQC accreditation.
Thank you for that, Pat. We'll make sure that those answers are given out to Mavis. I'll come back onto the screen now. Kevin, before I go to Kevin, thank you, Councillor Cruz, for sending apologies for Councillor Cruz. Thank you, Nick. On to Kevin now. You have a question, Kevin?
Yeah, did you want to take Ruth? She wanted to come back on something, Chair.
Please do, Ruth. I haven't got you indicated on the screen.
Sorry.
Come back in, Ruth.
It was just to add to Andy was talking about in terms of Mavis's question about will we reinstate everything that was there before, and Andy talked about primarily around the non-face-to-face consultations. The other thing that we have introduced is the arrangement whereby GPs are in much closer dialogue with specialists in the hospital over some specific conditions and pathways, particularly around things like the management of people with cardiology conditions or that kind of thing. And I was thinking that perhaps it might be helpful to provide OSC members with some case studies of how that's working, because it is meaning that people are getting a much more comprehensive package of care. It's something we were trying to bring in and had been trying to deliver very slowly over a long period of time, to introduce something which is ultimately an improvement in the way people are managed by their primary care clinician. And actually the experience of the pandemic's really accelerated that work in a very positive way. So what I was going to suggest is that we'll pull together some case studies to describe how that works, and then if the committee wanted a more detailed presentation about how it works in the future, we could probably bring some people who both have experienced it and some clinicians who are working in that environment as well.
I think that would be very useful for members, in particular, because as we all know, through experience from our constituents, etc., that there have been competing demands, as is highlighted in the report, and Andy has actually identified some. And there is a need, as you've mentioned, obviously, to get back to some sort of norm in terms of looking at the pressures caused by COVID, so we have something of a normal quote-unquote service operating as much as possible. And that paper that you've just mentioned, I think that'd be useful for us to have, to see how you're actually dealing with those competing demands as well as dealing with the COVID situation. Yes, I'd appreciate that tremendously, Ruth. Kevin, you want a question?
I did. I've got a couple of points, Chair. First of all, on page 3 of the report, page 13, agenda page 13, the next paragraph to the bottom that begins primary care is also working. The reference there to separating out the people who've been sent in by their doctor for something specific, separating them off from the A&E route. Is there any chance of making that permanent after the pandemic's finished? That was my first point, Chair. Second one was your own reference to the contributors having their own written pages there. And I think, like you, there was so much information coming out so quickly, I was having difficulty jotting it down. If the contributors do have their notes in a form that's suitable for distribution, that would actually be most welcome. And finally, just to support Councillor Tennant's comments, the service and the way things have run at the vaccination places has generally been quite well received. I think the only negative comments have come where people have received letters or from the national system to go to these mass vaccination centres, and sometimes those appear to have been sent out without reference as to whether or not are readily accessible from where people actually are, and sometimes not totally clear to the recipients that it's okay for them to say no to the national one if it's inconvenient, and that they will still be kind of dealt with by the primary care system. It would actually be advantageous as things move forward if all the invitations for people to sign up for vaccination, if they all came through the local GP service, and then there could be a little bit more of a fine-tuned attention given to the circumstances of the individual person. Thanks, Chair.
Thank you. Yes, I was going to ask for those reports that were so swiftly presented. That information would be valuable. And in terms of the GP practices and the vaccinations in general, I think we're all aware that probably, as Olivia's identified here in a comment, have we enough vaccine? Because there was some thoughts, if not actions, about the good work that had happened in Yorkshire, and therefore the amount of vaccine was going to be reduced coming in. So I think the people would like some answers on that as well. And in terms of the vaccination process, Kevin's made a good point. I'd like to add experience on the website. It was the most complicated, and even the personnel dealing with it admitted that the system was flawed. If you booked through 119 and you spoke to an individual about getting an appointment, etc., your first appointment was booked in. Then the system had to be directed to book a second appointment, and the second appointment may be available and booked in, but then you were actually told that the first appointment was gone and you couldn't have one without the other. But yet, if you go to your GP, or I'm assuming down to such a Sandal, that you can just have one. Now, this has been a fault on the system, and I've had several people connect me about it. And even the staff on the national system were getting very frustrated about having completed the one, then going on to the two, and then going back to the one to verify and complete the whole scenario, to find that the first one was gone, and therefore when that was gone, you lost the second one as well. So there has been problems with it, and locally, in terms of the system locally, that seems to be a much better way of dealing with people. That has been very positive. And I see here Olivia's asked about the vaccine, and how are we doing with the flow of vaccine into the Yorkshire area?
I think we've had assurance that we've got all the vaccine that we need for the week ahead, and that's really, as the programme has been rolled out very rapidly, that's really as much notice as we've ever had in terms of vaccine supplies. But we are confident that we're going to get the vaccines that we need in this area to manage the patients that are booked in for the week ahead.
Okay. Martin, did you want to come back?
Yeah, thanks, Chair. Yes, thanks, Chair. What I've just heard about appointments and vaccines is a little bit worrying. And going on to vaccines, but obviously with the flu vaccine, which people were encouraged to get earlier in the year, October, November, I paid for the private vaccine at a pharmacist, and they gave me all the information. I had to sign a form, gave my GP's address and everything. And I wondered where that information went, because I got a letter from the NHS at the end of December asking me to go for the vaccine. And I rang up my GP surgery, and they've no record of me ever having a flu vaccination from the local pharmacist. So I find out that information never gets to GP. So I just wondered why it wasn't connected up, and what happens to the information I give to my local pharmacy with all my doctor's surgery and other information about my health.
So my understanding is that information will get to your GP eventually. There probably is just a time lag in terms of that going through. I know I had the same experience. That I had the vaccine through my employer and then got a letter from my GP saying that I was entitled to it. But I think it's when you're vaccinating or running a programme on that scale, it does take time for the information to flow through the system.
What, 4 months?
Right, I don't know then why that's happened in that particular case.
My worry is if that's happening with the local flu vaccine, like Mavis has said, she didn't get a card or a letter, and what we've just heard about problems with the vaccine, it's just worrying.
Yes, that's a good point, Martin, and I'm sure our officers here today will take those points away and make some appropriate inquiries, because it is concerning. Not only in where's the information going, but the possibility that another appointment booked for somebody which is not needed is actually taking away an appointment for somebody who does need it. I can see Lynn Whitehouse, you want to have a comment? Hello, Lynn.
Yeah, I'm just going to back up what Ruth said, actually, that it's the part of the individual to let your GP know. But where I had mine done, my flu jab, it was attached to my GP's. I had to go in for different reasons, and I was informed that I could have it done there and then. But I informed, as I was told by the pharmacist, to tell my GP, which I did the same day. So that's how it gets rolled on, and you've got to have the responsibility of letting your GP know, because I indeed a crossover of a letter from my GP practice to say that I were due for my flu jab, but I'd already informed them, and there were a time lapse in between. But it's up to you to let them know, I'm afraid.
Okay, thank you for that, Lynn. I mean, this is the messages again going out in terms of what people should do and what they shouldn't do. The process is marvellous. Some of the messaging is a bit mixed, and particularly the national line, that could be a lot better. And now, Andrew Smith. Andrew, you said you're willing to answer the first part of 3 questions of alternative pathways attending the emergency department. That would be useful. Thank you, Andrew.
Thank you, Councillor. So we've worked extensively with our system partners, particularly our primary care colleagues, to ensure our emergency departments are kept for emergency, and I can speak with clarity on this as I am one of the emergency medicine consultants at Mid Yorkshire. And I worked late last night and saw where I can see my primary care colleagues are working very hard to ensure that patients only come to the emergency department where it's necessary. And I think this is a real, as Ruth said, this is a real positive of how we move forward. The COVID has kind of nudged us to work quicker on this, and I think that's a real positive. And it's important that we use our same-day emergency care facilities, we use our outpatients appropriately. But if a patient does need to attend the hospital, it's not always to come to the emergency department, so that we are available to be to care for the patients that really need that emergency care. And I've seen a real big improvement in this. We continue to work through this. We have the A&E boards working with my colleagues in the emergency department and primary care. We have really strengthened the pathways, and I think this is a real positive for the system.
Okay, thank you for that information. Earlier on, Andrew, you mentioned about patients going to Gooseberry Hospital. And obviously the elderly have been particularly susceptible to it, I know, in hospital, and we all get made known to us cases of where they've been discharged having contracted the virus in the hospital. I just want to put a question, and I'm sure a lot of people and a lot of members out there will have the same concerns, in that we have assurance that our older people who may have had to be admitted via A&E into Pindefears, then moved on to Gooseberry to release beds probably, maybe even in a step-down procedure, that they're not actually being discharged too soon back into the community or moved out of Pindefears too soon. Because we all know the older people, in terms of moving around, it does take its toll on them. And really the question is that there's no push to get older people out of Pindefears to make bed space, to move them on to Gooseberry without the appropriate support packages in place, even towards discharge.
Thank you, Councillor Chair. So yes, there's a very clear step-down process which we keep reviewing in line with national guidance. Obviously, Pindefears is our acute site, and we use the National Early Warning Scoring System, what's called the New Score, to assess our patients. For a patient to be considered to be stepped down, they have to meet certain criteria. They have to be an improving clinical picture, which includes their New Score being 3 or less for Gooseberry, and making sure their oxygen demand is reduced, and they have been apyrex for 48 hours. Then we consider stepping them down. And I think it's important that we do step patients down, because obviously it's freeing up acute beds, but actually it's moving people away from the acute site to a site where there's probably less risk of infection, because on the acute site you've got an influx of positive patients all the time. Obviously we are following all the measures I've described previously around social distancing and PPE. So there's a very clear structure how we step patients down and move to Gooseberry. And then with our system partners, we look at what's called the medically optimised fit for discharge list on a daily basis, or 3 times a day at the moment, because obviously we're keen to move patients when we can out of the hospital. But we do that for a very structured process, liaising with our system partners to ensure all the needs of that patient are in place so they can be duly cared for in the community. Obviously, we have to make sure that we have beds to take patients that require that acute emergency care into the hospital, and we can't be in a situation where we have ambulances unable to offload. So the flow is challenging. We must make sure we keep our flows, but in a very safe manner, to care for all our patients appropriately. And as I say, we do that in conjunction with our system partners through a very detailed process.
And to follow on, if I may, Andrew, we have seen in the south of England, and it was well known as well in the first phase of the epidemic, about the ambulance service being overwhelmed and having to wait outside Pindefears, etc. What's the waiting time for ambulance delivery at Pindefears?
So there's a metric we measure very closely. We should be able to offload our patients in 15 minutes. We then look at 15 to 30, and then 30 to 60, 60 to 120, and then greater than 120. I'm pleased to report this week there's been no what we call breaches of that, in the sense of no patients have been waiting to be offloaded for an hour. Last week was a slightly different picture. And as I mentioned earlier, we did put in measures which we can't take lightly. They are part of the major incident plan, and I'm obviously the major incident lead for the trust. So we did enact some of those aspects to generate some flow of our emergency department to enable ambulance to offload. That's a picture we obviously need to avoid. It's very important, because obviously we need our emergency ambulances available to attend to the next emergency call. So I hope people attending this meeting understand the complexity of maintaining flow through the hospital. So you have to make sure there's that enabled to flow off the ambulances into the emergency department, out of the emergency department, into the acute beds, and then when it's suitable, as previously described, those patients are stepped down to our Dewsbury site if we can. If they're not suitable, they stay on the Pindefears site. But maintaining that flow is a real challenge when the pressures are as high as they have been these last couple of weeks. But obviously we have very clear pathways that we follow and try to adhere to. And
in connecting your comments about A&E and your pathways and delivery within the service, because obviously Pindefears, as we know, is the centre, Ruth, you did indicate, and I spoke about it with you, and I'm sure Andrew is aware of it as well, is the triage service that's now in place at the A&E. As people turn up to A&E, they are directed to the most appropriate place, unless it's vital that they have to attain A&E. Do you have any report of how effective that's been?
I think the only report I can give really is that the pilot is going to be extended. It was going to continue until the end of January, but it's been very, very low numbers that it's impacted, and most of the people who have been redirected from A&E are people who really didn't need any follow-up at all. So, people who probably would have been better in the first place just going to the pharmacy or buying something off the shelf in the supermarket. But we can provide, I've got a catch up with the lead for that later on this week to just look at how we might roll that out as a longer pilot. And in terms of patient feedback, which is one of the things that we included, we've had no feedback at all. So none of the people who were involved in that gave any positive or negative feedback on it. So we will continue to do that for a little while longer. But as I say, it's not had a significant impact.
Yeah, I appreciate that, and that's good news. And lastly, to both of you, but I'm going to bring Olivia in after this comment. I did read a report where nationally there was a programme, an effort to recruit 2,000 nurses from abroad, and they were in various stages of their qualifications. Some who were in their last year, and some had already applied. Obviously within the rules of engagement in coming to the UK. Are you aware, Andrew, through the trust, of this national incentive, which obviously would be beneficial because of the amount of staff that are under pressure or sick or themselves involved in having to isolate? And is it part of something that the West Yorkshire Joint Committee are aware of? Because I think the initiative, if there is news out there about how it's going, it would be useful to have it. And I think that we all have to say, certainly today, that we are aware of the pressures that are on the staff and how the staff are having to work, and their families as well. But are you aware of this initiative at all, Andrew?
Yeah, Councillor, thank you. Yes, we are aware, and we receive regular feedback from our Chair of Nursing, and we have taken 150 of overseas nurses into this programme. They're in various stages of coming through. There's obviously quite a few checks that have to be done to ensure that they fulfil all the requirements. But yes, we are involved with that programme, and I believe the number is around 150 that programme of onboarding to the Trust.
And to follow that question up, Andrew, if I may, how many of those would be to fill any vacancies? Because nationally I saw the figures were about 30,000 vacancies. How many of those that will be recruited will fill vacancies? And then at the same time, through that recruitment process, are they going to be a fixed term contract? And if so, what would that contractual obligation be?
Thank you, Chair. I can't answer all that detail because obviously it sits with our Chief Nurse, but I can certainly go back and ask those questions and provide the detail you request.
That would be very helpful, and we can circulate that to members, because obviously staffing and the support of the staff that's there is very important and vital that we do what we can to help them. Olivia, I saw you put a message in. Would you like to have a comment?
Thank you, Chair. It was a comment. It was, I was quite surprised that there doesn't seem to be a long delay in terms of ambulances arriving and then having to dispatch their patients through A&E. Certainly last January, this is before the pandemic was recognised. I spent 2 hours with an ambulance driver admitting my mum last January to Pindefears. So it must be massive improvements if in fact that's not happening in a pandemic.
Chair, I can answer that. As I alluded to last week, we did have challenges. We enacted parts of Adrianston plan to increase flow. Since last January, Councillor Rowley, we've taken lots of steps, and one of those steps is having a consultant at the front door to ensure that we move flow as quick as we can. This is slightly a separate stream to the ambulance stream, but all those streams come through. So, for example, last night I was on the front door. I processed 42 patients through a extended triage process, what we call rapid assessment to treatment, and we often then pulling people off the what we call the green side ambulance queue. We've got the red side, which is the COVID patients have to go into the COVID side. But we are watching those metrics very closely. It's very important. We set our metrics going into pandemics, which we shared previously with this group. So it is our aim to offload those ambulances as quickly as possible, because it's so important to ensure those ambulances are freed up so they can attend the next emergency call. We do have challenges. Last week was a very challenged week where there were a number of what we call ambulance breaches. But again, we are trying our best to avoid that happening. And when we do get to a state where it's not acceptable, we enact part of our major incident plan so that we can take over other areas. For example, last week we had to use the paediatric area, what we call the green area, and we used that for some ambulance patients to go in, working collaboratively with our paediatric colleagues so they could use the children's assessment area still for children. So all these steps are complicated. It's a challenge, but we are using the metrics that we receive now for closer working with our ambulance service colleagues to ensure that we are monitoring it and responding to the pressures where we can.
Thank you, Andrew. Can I just refer now to the paragraph that's dealing with the issues of long COVID? The medical and professional view now seems to need to concentrate, as it says in the paper, involving all partners and clinicians because of the long-term issues about COVID and the long-term effects, weeks or months. We have Sean with us from the Mental Health Alliance. Hello, Sean. Nice to have you with us.
Chair, it's Martin. Can I just make a point on the ambulances before you go on to your next question?
Indeed, Martin.
Yeah, going back to what Olivia said, I mean, I've got two friends, and it was middle of December, and they were over 3 hours waiting to get in because they brought them a sandwich and a drink out to have in the ambulance. But saying that, when they were discharged at midnight after a week in hospital, they had to wait over 8 hours for transport. They kept forgetting about them, and they're diabetic, and they were concerned, Chair, that they were just being. I know it's difficult for the staff in hospital, but people that have got other underlying health problems shouldn't just be discharged and left in the hospital with and forgotten about.
What date approximately was this, Martin?
This was the middle of December, Chair.
Middle of December. Andrew, I believe when you gave an update that you indicated that there had been improvement since that time, is it?
Yes, there has been improvement, and again, when people identify for discharge, they go, if we can, we put them on the discharge lounge area, which is staffed. So I'd like to reassure people they're not forgot about, but clearly we are reliant on our partners in the ambulance service to then provide the facility for the patient. We are stretched, but we don't forget about patients. We do try and put patients in areas where there can be continued care for until that transport arrives. But again, I'm sure people can understand what we've discussed through just in this meeting of trying to generate the flow for the next acute patient that needs to come, that needs that urgent care. So if somebody's identified for discharge, ideally we move to the discharge lounge, which is staffed, and there are personnel to look after those while we're waiting for the ambulance provision. But if the ambulance service suddenly get a spike in demand, then they will have to wait longer, because we cannot, we can't dictate to ambulance service when a crew becomes available. So it's a very complex jigsaw, and I'm sure everybody in this meeting understands that our resources are limited, and they have been extremely stretched as we move through this third wave. But obviously, patient care is the centre of people's concern.
Thank you for that, but I can only tell you what I'm being told by the people, that friends of mine that have obviously, unfortunately have got COVID.
Coming forward, we're going to make a big thing about trying to.
I'm sorry, I can hear somebody one at a time, please. Martin, you were explaining that was the information that you had.
I thank him for that, but I can only tell you what I've been told by a couple of friends and other people when they've unfortunately proved positive for COVID and had maybe up to, I think it was 7 days in hospital. They just felt forgotten about. They said there were no staff about. So obviously you tell me they are, but they tell me there isn't. So obviously there might be. I understand the pressures, but obviously they were diabetic, and obviously they needed something to eat and drink, and that wasn't available for them.
Okay, I'm sure Andrew's taken those points on board, and maybe it's something you might want to reference back to make sure that that was maybe a one-off incident, because that is not acceptable. Now, I want Nick. I see you put a comment in here. Councillor Stansby.
Thanks, Chair. Yes, I just wanted to say maybe, Martin, it was a one-off, because everyone who's contacted me from youngest to oldest has had an absolutely better than average experience at both A&E and hospital stays. They've been well looked after. They've been taken in overnight. A&E attendants have been in and out within an hour and 3/4. Everyone I've spoken to who's been vaccinated, variety of combination of AstraZeneca and the Pfizer vaccines, they've all had a very positive experience. Very few side effects have been reported. So just to say well done, really, because in such difficult circumstances, I've been hearing nothing but positive comments from people I know and who have contacted me. So just to say that people have asked if I could pass on thanks to Wakefield CCG, really. So thank you.
Thank you, Nicola. Okay, Ruth, I can see that you're typing a message here. Do you want to speak to the message?
I will do, if that's all right. So I just wanted to say thank you for that. We'll feed that back. And I think just in terms of the other feedback we've received through this meeting, obviously the vaccination programme in particular is something that has been rolled out very quickly, and all feedback is good feedback at this stage, because we're in very close contact with the national team. It's all things that we can feed back to them in terms of the administration and the messages that are getting through to the public. In terms of the things that Andy and I in particular covered, I hadn't written any other notes. I just went off what was on the paper and my current knowledge. And I don't know if Andy had, but next week is the week when I would normally do the all council members briefing. So I'll just try and make sure that I wrap up some of this into that all members briefing, and then that can go out to all of the OSC members as well, if you want to do that.
Indeed, and it's always we always have to remind our presenters that come to the meeting today that the public out there, they may be connected today. They won't be the ones seeing the briefings that's going out to elected members. So it's important when we get an update, as we have done today, that can be backed up, that we can actually then, through the committee, have that on record as an up-to-date position. So I thank you for that, Ruth. That'll be very good. Now we've got Sean, who's been very patient, and he's waited there in terms of the long COVID, but not just the long COVID. We found out, as we all know through constituents and reports, about the impact of isolation and the impact on mental health care needs for people out there. Sean, would you like to bring us up to date? Because obviously we're all concerned that we speak a lot about the medical side, which is right, but we must never ever forget that this has taken its toll on the mental health of our residents as well. Are you able to update us, Sean, on what you're actually doing through your network and through your service to respond?
Yeah, thanks, Councillor Rhodes. So I brought a quite detailed report to the meeting in early December. Just to update on that, we've implemented the Wakefield and District Safe Space, which was in the planning stage at that time. That has been now launched. It was launched in a virtual way in terms of access, and now it is operating from the Arts House in the centre of Wakefield. In addition, since early December, we've extended the Psychiatric Liaison service to cover all age. And for members unfamiliar with that, the Psychiatric Liaison service works into Pindefears and Gooseberry and Pontefract to support patients who may come through ED or may need mental health support or on the wards. We've extended that to include specialist practitioners who work with children and young people, so that will operate now 24 hours, 7 days a week with those specialist practitioners available. And that has been a gap in service, and as Andy rightly referenced, we try to ensure that we divert or support patients who need mental ill health support away from ED. There are occasions when patients do arrive at ED, and that psychiatric liaison service is there to support those patients, and we're pleased that we think the children and young people's elements of it has made a significant difference for that client, those service users who are under 18. So those are some of the developments that have happened since December. Generally, we are continuing to ensure that we continue to provide services at all levels that we were pre-pandemic, but albeit in a different way. And we're acutely aware, certainly in the Wakefield Mental Health Alliance, for the continued need for support for voluntary and community sector organisations who work with people who, reference chair, may be isolated or in need of support, but may not have gone to their GP or indeed accessed NHS services. So going forward into next year, Wakefield will, just as all districts in the country, will receive an increase in money that is designed to increase the capacity for supporting community services. And we are working with primary care networks to ensure that money is spent in a way which is coordinated across Wakefield, and in a way which continues to support those elements that have worked well and we know will continue to be needed in the future, including voluntary and community sector organisational support through funding, but also more posts within community mental health services based in primary care networks. Now, the reality of that is across West Yorkshire and the country, everybody's doing this. The workforce is the workforce that we've got now. So we are recognising that there's probably a numbers deficit that we're going to have to address. When we're seeing increasing numbers coming out of universities with psychiatric nursing qualifications, but there is a lag. So I think it's important that I say, while we're all working on these really helpful increases in funding, the funding that we're going to get is going to have to be spent in a practical way until such time we get a full establishment of workforce in the community, because we don't want to deplete our existing inpatient wards, because we always have challenges of recruiting to those wards. So positively, I think we've been working in a coordinated way, kept service continuity, indeed expanded services that I've described and also are described in December. There's more expansion to come next year in the context of community mental health services that I've described. But we are mindful, as you referenced at the outset, Chair, of the demand from the local population for these services is likely to increase. So we need to ensure we find ways and continue to work with people like Health Watch and our own focus group and our own feedback information on how best we can do that in a way which is timely and in a way which continues to recognise the infection prevention and control aspects of the way we deliver our services. So I'll pause there, Chair, and happy to take any questions.
Thank you very much, Martin. I'm just picking up a message here about the server was lost to me for a little bit of time. Is everybody else connected okay? If I don't hear, I'll
Yes.
take that's you're okay. Right, okay. Yeah. My server is back on now. Thank you for that information. And it's interesting to see that we are always welcome of funds to be made available in terms of the mental health service. And over the years, obviously, your budget has been cut back, even though the demands have increased. I mean, the question I'd like to ask, and if it's not available today, Sean, I appreciate, is the funding that you're going to receive going to somehow break even on the cuts that you've had? Or are you still going to be running on a deficit, or is it going to enhance the budget, your budget? Can you hear me? Oh, dearie me. Can anybody hear me?
Yes, Chair.
Can you hear
I can
me?
hear you, Chair. Sorry,
That's
am I?
okay.
Hello.
I'm not. It seems. Thank you. Hello, Gillian.
Yes,
Okay. Sean, did you manage to get that question I asked? Sean, can you hear? I think we've lost Sean. Sean, can you hear?
Yes. Can colleagues hear me?
Did you hear the question I asked about funding?
I did. Can you hear me now?
Yes.
Yeah, thank you. So yeah, if there's a connection, so the funding.
The question
Nationally,
of funding was, being as you've had cuts over the years in your budget, does this funding that's coming from government bring you back to the status quo of your budget, or are you still running less than your budget existed in the past?
Yeah, well, we're not overspending in the Wakefield Mental Health Alliance, Chair. We operate services to the level of resource that we're allocated. I think what I'm emphasising to the committee is that resource is increasing for mental health support. So I remain, and certainly the colleagues in the Alliance remain positive, and you can see that increase in allocations to clinical commissioning groups. In Wakefield, the clinical commissioning group does have year-on-year uplift in mental health funding allocations. So we are in a positive position in that sense.
Okay, and obviously we're very concerned about the amount of young people who are reported, you know, having depression because of not being able to go to school, etc. Is there a waiting list for CAMHS, and if that's the case, how long?
We have seen some quite significant reductions in waiting times for the CAMHS service, and we reported at the Wakefield Integrated Care Partnership earlier this week those reductions in waiting times. And if I can just find a piece of paper with them on, which I've got in front of me. For example, in the longest, here we go, number of children and young people waiting for core child and adolescent mental health services was in October 2019. The longest wait was 19 weeks. It's now down to 0 weeks. And the number of children and young people waiting for assessment, there were 50 young people in October 2019. That's down to 17 on the waiting list for assessment. So we have invested in child and adolescent mental health services, but that investment with the expanded capacity, you can see some significant reductions in waiting times, and we have ensured that we have worked with the team and also our partners on the Children and Young People's Partnership Board to change the way we operate the service as well, and working with the team around the schools model with the Children and Young People's Wakefield Families Together partnership. We're also ensuring that our support into partners is improved and in accordance with that service model as well.
Thank you, Sean. Are there any other questions or comments to Sean? If not, I'm going to... Nick, do I see you've got a question?
Yes, thanks, Chair. Yeah, I've just been asked if, well, when we're likely to have a long COVID clinic, if we are at all.
So as I reported, this is something that we're working on, but I don't think we've got a definite time for when that's going to be launched. Pat has more up-to-date information than I have.
Right. Okay. I have asked the question of Mel a couple of days ago, but I mean it's obviously too early, so I'll go back to the constituent and let them know. Just a quick comment. I've been made aware of 4 attempted suicides in the last 2 weeks due to people being depressed during because of lockdown restrictions, and unfortunately one was a carer for his mum who'd had a stroke 25 years ago. The only thing he had that sort of in his life was snooker, and unfortunately because of the restrictions he's not able to play that anymore, so he felt he had nothing left and attempted to take his own life, so he's not in a position to look after his mum. But I've got to say that Adult Social Services have been out and made a full referral, and we're right on the case, and we are looking after her and she's sorted. But I do feel that we're sitting on a mental health time bomb. I think restrictions are really starting to impact people's mental health now, and 4 suicides in 2 weeks is 4 suicides too many. It's we need help. I don't know who I need to contact and who to refer people to, and are we putting on extra services for people affected by lockdown with the mental health?
Sean, do you want to answer that? I think probably, without going into too many details, right, 1 is too many to have to be known about. If Nicola wants to contact you about any details or support, then I'm sure you'll be able to oblige, because there are a list of avenues that can help people in these situations once they're known. So could I suggest if when you've got Sean to information etc. There, we seem to be having problems with Sean today. Anyway, I think we've had a very good report and contribution from everybody. But we accept the report, and obviously it's going to stay on the agenda for constant update and information for the members, as well as the competing elements is there for the NHS in terms of the other services. Can I thank our contributors today? I know you're all very busy, and commend to you and your staff our appreciation for all that they're doing in helping people through this dreadful situation. Thank you all very much. Thank you for your attendance.
Chair, just before you go,
Job well done.
Chair, just before you let them go, could I just ask, because it seems to be forgotten about, is track and trace. We don't hear nothing about it. We seem this vaccine coming along, but it's still out there, this virus, and we don't seem to hear about whether it's working, whether people are using it. I'm just wondering what the update is on it.
Ruth did mention it at the beginning in terms of the track and trace element. I'll call it an element because right from the start I think we'll all agree that nationally it was a disaster in many ways. I think public health and the local government working together have proved that local knowledge and local intervention and how you can deal with it local has actually been a prime example of local people knowing their communities best. And as you say, Martin, it has been a disaster. Ruth did refer to it. It's still out there. I think the emphasis has been now on the vaccine, but you're right. I don't think we've got to forget that the system now that's in place, as I say, with our public health, our local authority and other partners, seems to be, at this point in time, delivering on behalf of the people of the district. And I'm sure Ruth will keep us informed in that when you send out the update, Ruth.
Yes, I will do, yeah.
Okay. Thank you all very much, and thank you, members, for your engagement today. That takes us on nicely now to item 7 on your agenda, pages 17 to 18. It's the Chair's update, and you'll see that the issues there that's on your paper, the next steps building to strong and effective integrated care. I can confirm that this issue now is going to be picked up by the West Yorkshire Joint Committee, and I believe that that's next month. I've spoken with Andy, our officer, about access to dentistry. And I think this is something that we should put on our work programme, because I've had a case put to me and it's so long drawn out in terms of dealing with something. It's processes that we need to just look into. I had a briefing with Councillor Heptonstall and Beate and on the 25th of January, and the main issues discussed were obviously, as we've mentioned today, hospital discharge, care homes was top of the agenda, and the government's support for social care, support for carers, staff welfare, direct payments, and the budget update. And as we all know, and indicated by Councillor Rowley and myself on several occasions, we feel let down. I think every local authority feels let down by the government in their response to the funding elements of social care in general. That was one of the planks of the promises of the Prime Minister, and it has yet to happen after 4.5 years. I'm getting a link here that there's some limitations on the features, so we'll just have to be brief. I hope you can all hear me. And yes, it's still something that the government has put in the tax on local people of between 2% and up to 5% to pay for the elderly care and social care within our authorities. That's a tax on people, whereas the government have a responsibility and a duty to fund the local care. And I do believe that I know the authority has sent a letter to the Treasurer, to the National Secretary Treasury about this particular issue, so we'll see where it goes from there. On your report today as well, you've got the safeguarding adults, and all indicative of our concerns about safeguarding. We had the report from the Safeguarding Adults Board at our last meeting, and what we've actually done is we will be placing this as an informal briefing to be arranged for the committee on the work of the board, and hopefully by the end of April. And those are the updates since we last got back to work. Obviously, on top of that, queries to myself in terms of vaccination, GP appointments, and some reassurance really in terms of some of the mixed messages that still seem to be coming out to enable local people to understand the message. And I think in terms of the messaging, it's also important at this point that through the media we do get the message out to all our BME community and to everybody out there about making sure that they do look at getting the vaccination. There are lots of fake news out there which are upsetting people, but I believe that it's important that they get the right information about the preventative vaccine we hope is going to help everybody, and to take the opportunity of going and get vaccinated. So with that, that's my report for today. Councillor Rowley, I noticed that you indicated. Can you hear me?
I can hear you, but I don't think I indicated.
It's all right, love. I saw something come up on the screen.
Right.
Everybody okay with receiving that information? Okay. Item 8 on our agenda then today is the Care Quality Commission inspection reports, and obviously again providing members of Overview and Scrutiny with the details that the recently supported inspections have taken. And you will see again on the report today that we have 2 that's requiring improvement, and we have Whitwood Grange, Castleford, which is inadequate. Following the last meeting where we had concerns expressed about an establishment who had a 6 months inadequate report and then went on to be on the 12-month list for the inadequate report. We had a discussion with our briefing with Councillor Faith Heptonstall and Beate about this particular situation. And when this happens, there is a lot of work and effort that has to be put into by our social care staff in supporting these units to get back into a good position. Andy, you have been trying unsuccessfully, but we've now got some contact details to set up a meeting with the Commission to have a word about the system and how the inspections are carried out and the implications of the 12-month period, because obviously nobody wants to see a residential establishment closed down. But at the same time, when we're going from 6 months to 12 months, and the effort that's been put in by the local authority, then we need to make sure that those residents in these establishments, when it happens, are really, really well taken care of. And I do know that our social service staff do their utmost to make sure that that happens. So we did have a good discussion about that one, and we will have this informal meeting again so we can sit down and air our concerns, and maybe we might be able, through that kind of a meeting, to relay through the Care Quality Commission that perhaps some of the rules and regulations might need a refresher. If members will agree and accept that recommendation, if I don't hear from anybody, I'll take it that's agreed. Thank you. On item 9 is our work programme. Andy, do you want to come in on the work programme?
Yes, Chair, if I can, just to update members on the work programme. Members will be aware that in October last year we refreshed the work programme following the COVID outbreak. And what we did, we populated the work programme with a number of items that had dropped off the work programme, so to speak, as a result of a number of meetings being cancelled. Those issues were obviously highlighted again and back into the work programme, but since that was done in October, it's become clear that there's not been a lot of work done in those areas in relation to the identified. As a result of that, discussions with the Chair, we've agreed to actually again refresh the work programme, and again the Chair's indicated that one of those issues that will perhaps become relevant is the access to dentistry, which has been highlighted as a potential issue and the reasons why that would be the case. The other issue, I think, in relation to the work programme, and following on from the reports that we received in relation to the COVID-19 issue, is perhaps to look at the COVID-19 issue in relation to health inequality. Whilst COVID-19 has impacted on everyone in society, there is growing evidence that the burden of the pandemic is not equally shared. We know that it impacts unequally on older people, on minority populations, etc. And there are obviously other issues that in relation to inequality that are outside the health spectrum. So as a result of that, the Chair's agreed to actually put the health inequalities on the agenda for initial discussion, but I think it would be something that perhaps could be then referred to the management board as a wider issue, and in ways in which the scrutiny function could actually look in a more wider aspect at the health inequalities at the chamber itself. So, Chair, those issues that have dropped off the work programme will be reflected in a report that comes to committee at the next meeting, but will include the two items that we've just mentioned, access to dentistry and health inequality. If that's agreeable, I'll bring a report to the next committee outlining the scope of those inquiries and proceed in the way in which you would be, Chair.
Thank you, Andy. Yes, Simon, it's a terrible, terrible line. It keeps breaking up. Olivia, I can see that you've got a comment in. Do you want to come in now?
Sorry, it was about the previous item, but I'll wait until the further report comes through about the care in residential homes.
Okay, thank you. And I can see, Martin, you've made a comment that you've heard at the Bradford Road that the Glyn is closing. I don't know if Councillor Mrs Faith Heptonstall or Beatty know about this. I mean, obviously, then there's the issue of how many residents need to be placed where. But thank you for that. It'll be through. Okay, that's takes us then on to the item. Just let me get my pages through here. We've got the Care Quality Commission item 8. That's the one we've just been going to consider in terms of the inspection regime again. So we're going to take that one further and see what we can do. Olivia, do you want to have a comment on this one?
Well, my point was at the beginning of the meeting as well. We've had this discussion about the whole setup not being properly financed and waiting for this white paper. Meanwhile, we've got homes that people are paying to be cared for properly, and the whole system seems to be so inadequate and so sad. And of course, the ones that we've discussed before are horrendous, but one of the ones on this list is actually saying that people aren't safe to be based there. So it's a real concern that we've got people that we hope are being looked after adequately, and they're clearly not, and it's taking an eternity to resolve. It's not good.
I totally agree, Olivia. It's not good, and particularly when a comment like that is made in a report. I have to worry as to when a comment like that is made, what the regulations are, other than, as we know, 6 months to improve, and if that's not the case, then another 6 months. And this is where I think our discussions with the CQC and them coming to our committee, hopefully, is going to enable us to put forward our concerns in terms of the wording of this report, because obviously if that's a comment, well, it is a comment, then you would have thought, I would have thought, that it would have followed up by some recommendations on actions to be made safe immediately. But we will take it into account, and as we've said, in terms of the whole issue of the caring agenda and government funds, and when you consider that some of the costs that's placed on residents, then obviously in terms of their care, their health and safety, it's important that we as a committee do look into the circumstances and have a view and see what we can do to put an improvement either into the system or bring to the system our view of where we believe there are inequalities and inadequacies with it. I've got Beatty here who's been listening patiently. You're more than welcome, Beatty, to the meeting, and you want to have a comment, Beatty, today as the Standing Director for Social Care?
Thank you. Just notwithstanding everything people have said about the CQC responsibility and the inspection regime, I think that will be a very useful discussion, and the concerns of the committee quite rightly can be put to the CQC. But just to reassure committee members that whenever there are any concerns around safeguarding, as in the report highlighted, then our teams will immediately work with those homes and with the CQC to make sure that actions are put in place to ensure basic safeguarding. So the fact that it takes some time for the report to be published doesn't mean that we haven't been working with that establishment. Progress has been made, but that's really just a comment on what's happening to support the residents and ensure that the welfare of the residents remains absolutely paramount.
Thank you for that, Beatty. We feel reassured. We know you and your staff are doing your utmost. Andy, you wanted to come in with a comment?
Just clarification, Chair, if I may, in terms of the meeting itself. I'm grateful to the Adults Directorate for providing the appropriate contact details for the right person. That's been very helpful because it has proven difficult hitherto. But just to clarify that the meeting is being arranged, as soon as that's a date been arranged, I'll obviously let members know of that particular date. What I would ask, Chair, if this was all right for the committee, is that if dates do prove problematic in terms of our scheduled meeting, we need to be open to organising an additional meeting with this particular item as being the main agenda item.
Indeed, Andy. I think that's a given from the committee that it is an agenda these days in terms of what's happening to COVID and everything else. But this is equally important, and as and when we do, then yes, certainly, I'm sure the members would support an additional meeting to have this as an item that we can really delve into and ask the appropriate questions and pass on the appropriate comments. Martin, you have a comment?
Yes, Chair. I'm just concerned because there must be really serious issues if after 6 months things aren't put right and then you're given another 6 months. It must be really bad, and one wonders why after 6 months they still have not made the improvements.
Well, those were the concerns expressed last time, and I know that we'll express those as we go along. You're right. This is the avenue we're going to explore, Martin. Thank you for that. Clive, I know you've indicated here, and you need to leave the meeting now. Can you hear me, Clive? Anyway, Clive, Council Tenant did indicate. Yes? We have a very bad line today. Clive indicated that he might have to leave the meeting at 2:45. Can you hear me, Clive?
Yes, thanks, Chair.
Did you want to make a comment, or are you leaving now?
I'm going to leave now, Chair. Thank you.
Okay, that's fine. We've come a long way on the agenda. Thank you for your attendance. Kevin says he's just got his vaccination appointment for tomorrow tea time at own GP surgery. Fill in a gap, I would guess. Well done, Kevin. I'm sure everything is going to go well for you, love. Okay, now that takes us to the end of our agenda today. The date and time of the next meeting is on the Thursday, the 25th of February, obviously at the same time, 2 p.m. So with that, apologies today. We've had a bit of ins and outs with terms of the line we've had. We've been lucky to keep going, as I understand this morning had more interruptions than what we've had, but there you go, we've managed. So thank you all for your attendance, and I'll declare the meeting closed, and keep safe to you and all your family. Bye-bye for now.